Our learning objectives are to identify the common causes of dilated thoracic aorta, discuss the clinical and imaging clues that aid in the diagnosis, and review the indications for surgery. Thoracic aortic aneurysms are typically asymptomatic, and they are frequently an incidental diagnosis. They are often identified when a patient undergoes an imaging study, such as a transthoracic echo or a CTA. The etiology of the aortic dilatation determines the management and may have implications for both the patient and the family members, so it becomes critically important for us to identify why the patient has aortic dilatation. The most common cause by far is acquired diseases of the aorta, typically degenerative aneurysms from things like hypertension, smoking, or atherosclerosis. It's really important that we recognize the inherited aortopathies, things like MARFAN syndrome, because these are very severe disorders that can affect multiple family members and can have different types of management issues. The CT here shows a classic patient with MARFAN syndrome with this pear-shaped aortic root dilatation. The final disorder I want to discuss is the inflammatory disorders of the aorta, such as vasculitis or aortitis. These are uncommon, but I think it's important that you know how to recognize these so that you can make the diagnosis. It's important that we make these diagnoses because elective intervention comes with a much lower risk than intervening when the patient has an acute aortic syndrome. So we want to identify the presence of dilatation, understand when we need to intervene, and appropriately refer patients for surgical intervention. When I'm meeting a patient for the first time with a dilated aorta, there are several things that I use to help me determine what's going on with the patient. So the first discriminator is age. Obviously, if a patient in their 20s or 30s presents with a significantly dilated aorta, that's going to push you more towards the genetically driven disorders. Then we look for the risk factors for degenerative disease. So if you have an elderly patient with a dilated aorta who has smoked for 50 years, has long-standing hypertension and hyperlipidemia, that's going to push you towards the degenerative disorders. We look at where the aorta is dilated. The genetically driven diseases typically affect the aortic root or the sinus of Valsalva, the very first part of the aorta, while degenerative disorders and bicuspid valve more frequently affect the mid-ascending aorta. We look at our imaging and we see if there's aortic dilatation in multiple vascular beds. The genetically driven disorders more frequently affect things like the visceral bed or the iliac arteries or the arch vessels. So this can be another clue to us. We always take a careful family history, and this is more than just asking about a history of Marfan syndrome. I like to ask patients, has anyone had an aortic dissection? Has anyone required aortic surgery? Or have there been any unexplained sudden deaths? And sometimes you'll get a history that multiple family members died suddenly in their 40s, which often is attributed to coronary artery disease. Then we do a careful physical exam, and we look carefully at our imaging to see if we can find any other clues. We'll go through some of these things in more detail when we talk about the different disorders, but I'll just show you a couple examples. So we look for the presence of a pectus deformity. We look in the patient's mouth at the uvula. This is a bifid uvula, which is a very specific finding for LOEYS-DIETZ syndrome. And then we look at our imaging. Things like sacral dural ectasia is prevalent in Marfan syndrome, and the presence of tortuosity of the arch vessels is more common in LOEYS-DIETZ syndrome. Now, a couple of words about imaging. When we're talking about the aortic root and the proximal ascending aorta, it's really important that our CT or MRA images are gated. We do this to get rid of motion artifact. So here you see an image without ECG gating, and you can see that performing an accurate measurement of the ascending aorta would be very challenging. But when we apply ECG gating and we freeze motion, we get beautiful images, and we can very accurately measure the aortic diameter. And when we measure with cross-sectional imaging, we want to be measuring at reproducible landmarks, and we measure the external diameter in a double oblique format. So what I mean there is we want to be perpendicular to flow in two separate planes, which gives us this nice double oblique image so we know that we are not going to over or underestimate the size of the aorta. At the sinus of Valsalva, we want to measure the widest diameter, so from sinus to sinus, the biggest diameter. Sometimes you'll see measurements from the sinus to the opposite commissure, and those measurements are going to be much smaller. The The most important thing for an individual patient is that we're using the same technique and we're measuring at the same location using the same imaging format in order to make sure that there's a true change when we see a reported difference. When we talk about indications for surgical intervention, for a degenerative aneurysm, the cutoff is 55 millimeters. For MARFAN syndrome, it's 50 millimeters, using 45 millimeters if there's a risk factor for dissection or if the patient wants to have a valve sparing operation, 40 millimeters if it's a woman with a desire for pregnancy. And in LOEYS-DIETZ syndrome, it's a very aggressive disorder, so we use a cutoff of 40 millimeters. In vascular EHLERS-DANLOS, there is no size indication for cutoff because patients typically will have abnormalities of the aorta even at a normal diameter. For bicuspid aortic valve, the cutoff is 55 millimeters. There is a 2A indication to use a size of 50 millimeters if there's a risk factor for dissection, or in a low-risk patient who has no risk factors if their surgery is going to be performed on comprehensive valve center. And then there's a 45 millimeter cutoff if the patient is going to undergo aortic valve surgery. So let's talk a little bit more about the different types of aortic diseases. So for the degenerative aneurysms, these are the most common by far. This is what we're going to see most frequently in our patients. It's going to be an older patient who has multiple risk factors for an aneurysm. And these patients typically will have sparing of the aortic root. So here in this 3D image, you see the sinus of Valsalva is actually relatively normal. And then from the sinotubular junction up, you see this sort of diffuse dilatation. I think it's important to recognize that the normal size of the aorta varies. So men tend to have larger aortas than women. And as patients get older, and also patients with a larger body size, the normal values vary. And so we use nomograms, and there's a variety of reference documents available to determine what is truly abnormal for a patient. When you have a patient in their 80s who's a large man, the normal aorta may go up into the 40s, 42, 44 millimeters. For all of these patients, we want to be very aggressive with controlling our risk factors, things like hypertension management and smoking cessation. And then if the patient is first diagnosed with an echo, we'll often do either a CT or an MRA to confirm the diameter and make sure that we're not missing any parts of the aorta that we don't see well with echocardiography. We usually recheck the dimensions within 6 to 12 months. If it's stable, then you can go to yearly. And once a patient's had a stable diameter for a couple of years, you can space out the imaging and make it even less frequent, especially in the older patients. And as I mentioned, the indication for surgery in these patients is a size of 55 millimeters. So now let's break down these different inherited aortopathies. I really want to focus most of my time on these genetically driven disorders because these are the disorders that I want you to be able to recognize when you see one of these patients. So we'll start with a case. This is a 60-year-old man who presented to the emergency department with chest pain, and his CT demonstrated a type B aortic dissection, which you can see right here starting at the left subclavian. Now in this case, we had a very astute radiologist who also noted that the patient had a dilated aortic root at 51 millimeters, had a pectus carinatum deformity, and had sacral dural ectasia. So the radiologist actually said, you should consider MARFAN syndrome in this patient. And sure enough, when I saw this patient, he did have typical features for MARFAN syndrome, including a history of ectopia lentis. So MARFAN syndrome is the most common systemic connective tissue disorder that we see with a prevalence of about 2 to 3 per 10,000. It's an autosomal dominant disorder like all of the genetically driven aortic diseases. It's due to a mutation in the fibrillin-1 gene on chromosome 15, and this mutation causes increased TGF-beta signaling, which leads to weakness in the wall of the aorta. Patients have this very typical dilatation of the sinus of Valsalva. So in this MRA, you can see this significant dilatation, and this described as a pear-shaped aortic root tapering down to a more normal diameter. And then this is another patient that I saw recently with severely dilated aortic root and a very severe pectus excavatum disorder here. So when we make the diagnosis, we use something called the Ghent criteria. These were revised in 2010. And so the diagnostic criteria look like this. If you have a patient who has a positive family history of MARFAN syndrome, In order to make the diagnosis in that patient, you only need one of the following. You need either aortic disease, which is dilatation, or an aortic dissection. And we use Z-scores in these patients. So for young patients, it's a Z-score greater than 3. For patients over 20, it's a Z-score greater than 2. And if you're not used to using Z-scores, the MARFAN website, this website right here, they also have an excellent app. They have a Z-score calculator, and you can use that. If you don't have this, you also look for ectopia lentis. So this is a dislocation of the lens of the eye. It's a very specific finding in Marfan syndrome, or a systemic score greater than 7, and I'll go through this on the next slide. Now, if you're seeing a patient who does not have a known family history of Marfan syndrome, but you're suspicious of this disorder, then we look at things like the presence of aortic involvement, so either a dissection or dilatation, plus a dislocated lens in the eye, aortic involvement and a pathogenic fibrillin mutation, or aortic involvement and a systemic score greater than 7. So what is this systemic score? So it's listed here, and I mentioned this Marfan website, and so both the website and they have an app which has a calculator built in, and the calculator and the website will show you pictures of all of these things. If you've never seen some of these things, I've shown you some dural ectasia. And on the next slide here, I'll show you pectus excavatum. This is the thumb sign. This is the wrist sign. This is the sacral dural ectasia. So basically, you just go through with your patient and you add all of these up. And if your score is greater than 7 and you have an abnormal aorta, then that meets criteria for Marfan syndrome. So in the patient I presented to you, the type B dissection was stable, but he had a significantly dilated aortic root in the setting of Marfan syndrome, so we referred him on for elective surgery. We did recommend genetic testing, and it wasn't done for financial reasons, so then we recommended screening of his first-degree relatives. And so this recommendation is from the thoracic aorta guidelines, so all first-degree relatives of patients with aneurysms or dissections should be screened. And if you find one or more relatives with aortic disease, then you extend your screening to the second-degree relatives. Genetic testing is incredibly helpful in these patients, but you really need to collaborate with a geneticist and a genetics counselor. If you find a disease-causing mutation in a patient, you can then use this to screen all the first-degree relatives. But if you perform genetic testing and you don't find a mutation, or if testing isn't performed for a number of reasons, then you need to image the patients for screening purposes, and we typically use a transthoracic echo for this. So here's our patient's 24-year-old daughter. So we referred her for a screening echo, and you can see here her sinus of Valsalva measures 45 millimeters, so that's a Z-score of 3.2. So if you remember from our Ghent criteria, positive family history plus a Z-score greater than 2. So this patient now also meets criteria for Marfan syndrome. So our next step with her was to refer her for an MRA, which confirmed that our diameter was accurate. So now we have to treat the patient. So for all patients with aortic disease, we want strict blood pressure control. In all patients with Marfan syndrome, they should be on a beta blocker, even if they don't have hypertension. And this is because beta blockade significantly decreases the risk of aortic dilatation. We can also use angiotensin receptor blockers. Multiple studies have shown that they're not inferior, and they actually can also slow the rate of dilatation in patients who are already on a beta blocker. And just from taking care of patients, these are often better tolerated than beta blockade, particularly in the young patients. Important things to avoid. We want to avoid calcium channel blockers in Marfan syndrome. This is based on both a Marfan mouse model, which showed that treating these mice with calcium channel blockers showed accelerated aortic disorders. And then from a retrospective review of patients with Marfan and other genetically triggered disorders, those taking calcium channel blockers had increased rates of dissection and increased need for aortic surgery. So we really want to avoid the calcium channel blockers in these Marfan patients. And then we also want to avoid fluoroquinolones. These have been associated with an increased risk of aortic dissection and aortic growth. So we want to avoid them unless there's no other treatment option for these patients. So back to our young woman. So we made the diagnosis. We started her on a beta blocker. We repeat imaging 6 months later, and the aortic root has grown from 45 to 48. Her blood pressure is excellent on metoprolol therapy. So now what would we do next? We could do another MRA, but we know that our MR correlated nicely with our echo. We probably aren't going to be able to add much losartan given her blood pressure, so maybe now it's time to think about referring her for surgery. So in the patient with MARFAN syndrome, the indication for surgery is a diameter of 5 centimeters, unless there's a family history of dissection at a smaller diameter, any evidence of rapid expansion, and we define this as 5 millimeters per year. So in our patient growing 3 millimeters in 6 months, she does meet criteria for rapid expansion. Or if you're developing progressive aortic regurgitation or you want to perform a valve-sparing operation. For any of these reasons, you can consider going at a size less than 5 centimeters. In a woman who wants to have a pregnancy, we use 4 centimeters as our cutoff because pregnancy is a high-risk time for these women with MARFAN syndrome. And then some institutions use this cross-sectional area divided by height. So our patient was referred for surgery, and she did very well. She had a valve-sparing operation, and this echo was performed relatively recently. She's now, I think, 6 years out from her valve-sparing operation and doing well. So now let's talk about some of the other disorders. So LOEYS-DIETZ syndrome, there's a variety of different mutations. The first one described was the TGF-BR1 and 2 mutations. There's also the type 3, which is a SMAD3 mutation. These patients get accelerated arthritis. There's type 4 and type 5. And the basic premise of all of these is there's abnormal TGF-beta signaling. So we treat all of these patients with ARBs, aiming for the highest dose they can tolerate. Again, these are dominant conditions, and these patients have a really increased risk of dissection even at small diameters, and so we refer for surgery at a diameter of 40 millimeters. So the clues on exam are things like hypertelorism or wide-spaced eyes, the broad or bifid uvula, which I mentioned before, the presence of tortuous vessels, cleft palate or club feet, so we take a careful history. And these patients also have an increased incidence of asthma or inflammatory bowel disorders. We don't have clinical criteria, so we refer these patients for genetic testing. And because any vascular bed can be affected, we do annual imaging with MRA or CTA from the head all the way to the pelvis. And if one of these patients needs to go to surgery, we do cervical spine x-rays because of a history of cervical spine instability. Let's look at another case of a 24-year-old man who comes to the emergency department with abdominal pain and hypotension. CT shows a ruptured splenic artery aneurysm, a hepatic artery aneurysm, and a complex subclavian artery aneurysm, which you can see right here. So very unusual for a 24-year-old man. He has a history of clubbed feet, he has very translucent skin, hypermobile joints, and he was recently diagnosed with elastosis perforans serpiginosa, and this is what this looks like. So this patient went to emergency surgery for the ruptured splenic artery aneurysm, and his tissues were noted to be very, very fragile. And his genetic testing did confirm a pathogenic mutation in collagen 3A1. So this patient has vascular Ehlers-Danlos syndrome, and this is this patient's legs here. And so these patients have very thin translucent skin. You can see all of the veins in these patients. And these patients have very fragile tissues, the arteries, the intestines, the uterus, and the vast majority of patients, 80%, will have had some sort of clinical event by the age of 40. This disorder is very challenging to care for because the role of surveillance imaging is really unclear. Any surgery is complicated by the very fragile tissues and poor wound healing, and often arterial complications can occur even at normal diameters, so it's hard to know what to use for a cutoff for intervention. There's some thought that beta blockers may be helpful. The celiprolol was studied, but it's not available in the United States. Pregnancy is an incredibly high-risk time for these patients due to the risk of mortality. And there's an increased risk of complications with any procedure, so we really want to avoid invasive procedures like angiography or colonoscopy to avoid the risk of complications. The final group we'll talk about is the familial group. So these are our patients who have no syndromic features but have significant aortic abnormalities. Again, this is a dominant trait, and there's many genes implicated. So the current panel that we use tests for 35 genes known to be associated with aortic disease. We don't have data on the use of beta blockers or ARBs, but we frequently use these medications for these patients. And we screen family members just like in the other disorders. And this is an example of the significant aortic disease that can occur. This was a young man with no syndromic features and negative genetic testing, but a really, really huge aortic root. I mentioned bicuspid valve. Aortic dilatation is common. Dissection is actually very uncommon in these patients, but more common than the general population. And that's why the indication for surgery is a size of 55 millimeters. And then I already mentioned the reasons why we would consider going at a size of 50 millimeters. And then if the patient's going for valve surgery, we would intervene if the aorta is 45 millimeters. So the final case I want to highlight is a 74-year-old man with a dilated ascending aorta who came for a routine echo. And during his echo, we found his mid-ascending aorta measured 52 millimeters. And just 1 year ago, it was 45 millimeters. So this is a really significant change. In reviewing his chart, he had increasing symptoms of fatigue and an unintentional weight loss over the past 8 to 10 months. And he had a new normocytic anemia with a negative workup. So we performed inflammatory markers, which were markedly elevated, and performed a CTA, which confirmed the increase in the size of the aorta up to 51 millimeters, but also showed this increased wall thickness surrounding the great vessels, suspicious for vasculitis. And then we proceeded with a PET scan, which showed diffuse uptake suggestive of aortitis. So aortitis is an inflammatory disorder of the aortic wall, and it's an uncommon cause of aortic aneurysm. Infectious aortitis is very uncommon, and what we typically see is non-infectious aortitis. So in a patient over the age of 50, it is almost always giant cell arteritis. And this is kind of the typical CT imaging. Often the sinus of Valsalva is normal, and then you get just really diffuse aortic dilatation of the entire aorta. And with your cross-sectional imaging, you can see increased wall thickness in the acute inflammatory phase of aortitis. Giant cell is the most common vasculitis in the elderly. Patients can present with cranial symptoms or extracranial symptoms from the aortic involvement. And in a big review from our institution, the vast majority of patients were female, and almost half had aortopathy, most commonly being aortic dilatation. Very infrequent dissection, but the important points to highlight here are those who dissected were those who grew rapidly, and oftentimes even at sizes less than 50 millimeters. So really important to recognize this as the etiology of aortic dilatation. So in summary, it's really important that we understand the etiology of aortic dilatation in order to appropriately manage the patients. We want to use all of the available imaging from our history, from our physical exam, and from our review of the imaging. We want to aggressively treat hypertension if present. Even if patients don't have hypertension, they might need therapy with either beta blockers if they have MARFAN syndrome or an ARB if they have LOEYS-DIETZ syndrome. Don't forget to screen the family members, and then refer for surgical intervention in order to avoid complications, remembering that the etiology is going to determine when you refer for surgery. Thank you very much for your attention.